My name is Anika Daniels Osaze, and I am the Director of Diversity, Education, and Research for the College of Medicine here at SUNY Downstate Medical Center. And I hope you're having a fabulous time. I expect all of you to be taking copious notes because we have a lot of fabulous information here. We have great speakers, and all of the people here are well equipped to give you the knowledge that you need to move forward in any area of healthcare that you are currently serving in. So I have the pleasure of moving into the next segment of the conference and introducing our speaker who will be discussing adherence promotion interventions. Here we have Dr. Daniel Suka, who is the Associate Professor for the Department of Psychiatry and Behavioral Science. So we'd like to get right into the presentation because we are running a little bit low on time. So Dr. Suka, I'd like to welcome you to the podium at this moment. Thank you.
Hello, everybody. How are you? My name is Daniel Suka, as you just heard. I am a clinical psychologist by training. I am also serving as the research scientist at the Health Disparities Center. The reason why I say I'm a clinical psychologist by training is because what we've been hearing all morning is kind of this really broad, big view, and that makes me nervous because I don't know how to fix any of those things. But as a clinical psychologist, I do like sitting one-on-one, talking to people, trying to figure out how to help this person in this room move forward. And that's a little bit of what I would like to share with you today, as some of the work that we've been doing. I'm piloting a new style of slide presentation here. Hope it works. So today, the theme is adherence. And I would like to talk about adherence from a couple of different perspectives. First, I would like to talk about, well, what does it mean to be adherent? And we've heard a little bit about that already. Then I'll talk about why are people non-adherent, which we've also heard a little bit about. And then are there ways of getting people to become more adherent? And I'll share with you some of the data from the clinical trials that we've been doing here at Downstate. So back to our initial question of what does it mean to be adherent? And when you sit with someone, I say this is a lot like the question of, what is it the same thing as saying, are you a good person? What does it mean if you are a good person, right? Well, I do like 9 out of the 10 of the big commandments, but I cheat on my taxes. Are you a good person? Are you a good patient? How do we know who is a good patient and who is not a good patient, right? Who is really doing what they need to do, and whose definition, right? Who gets to define? If you ask people, are you taking all of the medication that you're supposed to be taking? They often will say yes, and you'll go through the list. You go, oh, well, I don't take that one, right? So then, well, who makes the list of the medications you're supposed to be taking? So how do we go about thinking about, what does it really mean to be adherent? So another way of thinking about it, is it a measure of a general trait, or is it a specific behavior or a dimensional, kind of a very particular, do you take this pill in the morning? Does that make you an adherent patient? It really depends. So how we define who is adherent is very different depending on the type of study that we're trying to do. So I'm going to be presenting shortly some of the results of some of the work that we do, but again, we're not using a really broad definition of adherence. We're using a really narrow definition of adherence. So what we have to do is we have to operationalize it. For each study that we do, we kind of reduce it to, well, this is the key behavior that we think that is important for these types of patients. So this is the one that we're going to study. But the amount of ask, the thing that we ask all of our patients to do is much broader than all of the things that we're able to measure. And even though it's a limitation, I actually think it's an important strategy, because if we're thinking about how to allocate resources. So, what are the most important measures that we really want people to be improved on or to increase their adherence to? So it is, part of the task of the researchers is figuring out, what are the key measurements, how do we measure that, and then can we make changes on those measurements? So there are different domains of adherence, and we've kind of been hearing a little bit about this from the different speakers. This is just one organizational structure that I like. So, there's medication adherence, which is taking the right dose of the medication at the right time. There's appointment adherence, going to the visit when you're supposed to go, getting the test done that you're supposed to get done. Then there's dietary compliance, and depending on the illness, there's different foods you're supposed to be eating, not eating, fluids you're supposed to be having, too much, too little, what you're supposed to be having. And there's treatment adherence. Are you actually doing the things that the doctor asks you to do? And then there's behavioral adherence, which is like exercise, cutting back on smoking, stress management. So that's a lot, right? I mean, that's a lot of our lives. So those are all different domains of adherence, and depending on what illness a patient might have or what particular goal we would like to work on, we could fall into one of these domains, many of these different domains. But in terms from a research perspective, we really need to think about, is it the same? Back to my first question, if you give somebody a medication and they take it well, does that mean that they're likely to also be compliant with the treatment that you've prescribed as well, or the diet that you've prescribed? Is there really such a thing as an adherent patient? Do they do all the things that we're asking them to do, or are people really pickers and choosers? Well, that I do, that I don't do, that I'm never going to do, that I'll think about doing. So how does that really work? I don't think we even know the answer to that, right? I mean, we don't know from a scientific perspective whether adherence really even travels as a kind of general characteristic trait of the patients that we're treating. So why are people non-adherent? We've heard many different versions of answers to this question. I'll share with you my approach because we're people, right? Everybody is non-adherent. And if you start off with the assumption that I'm prescribing a drug or I'm telling you to do something, and therefore you're going to do it, by definition, you will be disappointed, right? So in mental health, I come from a mental health background. I think we're well seasoned at the expectation that nobody's going to listen to what it is that we tell them. It's more shocking, I think, in the medical community when they say you should do this, that people don't go and do it. So I think if you have a different perspective as a clinician, you understand that, well, this is what I think you need to do. Well, let me find out what it is that you think that you need to do, and let's see if we can have a conversation about that and see if we can move forward. So to kind of back that up in a little bit of data, so this is a study that we did on 312 kidney transplant patients all across New York City and targeting different ethnic groups and different socioeconomic status. So we had a group from Brooklyn that identified themselves as African American. There was a group in the Bronx that identified themselves as Hispanic or Spanish speaking, and then there was a group in Manhattan that was predominantly Caucasian. And what was interesting, I'm not showing that data here, but what was interesting is, yes, there were differences between the ethnic groups, but that's kind of complicated because they were all from different places. But when we really looked at it, there were the primary driver of the differences was not really ethnicity, it was the belief in the medication. If you thought that this medication was important to you, then people took it. If you didn't think it was important to you, then you didn't take it. And that cut across all races and all socioeconomic status. Now, it happens to be that there's a higher prevalence of people in both the Hispanic group and in the African American group that had less belief in the medication. But to me, that's a very different question, right? So now I can begin to understand how we're going to develop an intervention. So this particular slide that you have in front of you, look at that. So what you see here is people that in the blue are the people that were very adherent, and the people that were in red are people that were not very adherent. And the point of this is that these are all the different questions that we ask them, potential reasons why people don't take their medication. And if you look, people that are not adherent, were higher on all of them, right? It's not like there's one particular reason. There's all of the reasons kind of combined together why people don't take their medication. Another observation that I would make is that, even the people that are very, very adherent, this blue line, these numbers are not dramatically different than each other. They all had problems, right? There were too many pills per day. There were too many medications at once. They did have, on the other side, they do skip meds when they're low on money. They do miss meds when their daily routine went awry. All of those things were true for lots of people, more true for the people that ended up being non-adherent. But adherence is really a challenge. And I think one way of thinking about, like I mentioned, allocating resources is that it's challenging for everybody. But there's like a large majority of people that do pretty well. And they take their medication and they come to their appointments, they do the things that they need to do. And then there's a sizable minority of people that don't, right, that are not as adherent as the rest of the group. And those are the people I think that really need to be paid more attention to and perhaps supported in their ability to take their medication and find out kind of what's going on with those people and what those reasons might be. So this is a study that we're ongoing now. I just kind of put this together for this talk. This is looking at lupus patients. It's only 28 people, but what I thought was kind of astonishing when you look at the shape of this, it's the same questionnaire. When you look at the shape, I'll go back for a second. It's like the same shape. Different disease, different group of people, Same shape, right? So to me, as a psychologist, it's not a disease problem, it's a people problem, right? I mean, these are the issues that human beings have. And if you have, if you have one set of medical challenges, doesn't mean that you would necessarily behave entirely differently if you had a different set of medical challenges. This is how human beings respond to different challenges. Okay, so then, are there ways of getting people to become more adherent? And what I would like to do is share with you two different studies that we have done here, and I hope the answer to that question is yes. So the first study is adherence promotion in kidney transplant recipients. So if someone has kidney failure, there's two types of treatment. Certainly the best type of treatment is to get a kidney transplant. It's healthier for the patient, but it does come with a challenge that they have to take medications, immunosuppressants, so they have to take medications so they don't reject this foreign kidney, and they have to be very good at taking the medication as prescribed. And in fact, there is a whole field, really, of medicine, of transplant nephrology, which is Dr. Salafu does, and how we initially met, which is devoted to figuring out the exact right dose for taking the medication. But it's all predicated on the fact that people are going to be taking the medication in the way that we have expected them to. I mean, it's such a careful balance of what they're trying to achieve that sometimes even relatively small amounts of non-adherence can throw off months or even years of a relatively stable kidney. So the clinical trial, I don't know, it's a small clinical trial. We randomized 33 people, 15 went into our intervention, 18 went into our control. I'll tell you a little bit more about what we did. So it was a 2-session intervention, right? We met with a group of patients twice, and what we did was, these are the different components of what we did. So we talked about education. So these particularly transplant patients, they've gone through a lot of education. They really understood very well, in fact, better than I, why they needed to take these medications. They had heard all the things that the physician said, but we wanted to kind of give them an opportunity to say it and to really show that they've really owned that bit of information. And we talked about their individual barriers and, what were the challenges that they had as a group. And, sometimes there were common barriers, sometimes there were individual barriers, and then we kind of moved into this motivational interviewing, which was really trying to get people to find the motivation to really change. And then, once they got that motivation, we started to put a plan into place, and we did some behavioral modification. And then, here's what we should do. This is your particular plan. Your issue is you don't take your medication when you're not feeling well. Okay, why is it? Oh, it's because it's really hard to get out of bed or to go there. Okay, so what happens if you had an extra dose in your nightstand? Oh, I never thought of that. Okay, kind of a really practical, pragmatic plan. And then after we did that, we talked about, well, are there other more emotional reasons why perhaps you don't take your medication? And I think there's like this undercurrent to all the talks that we've been hearing today about the demoralization, about the depression. I see it going as both ways. Certainly when you're feeling poorly, who wants to do anything, let alone do stuff that is going to help you, down the road. And also, when you are really feeling sick, it's really hard to kind of have your spirits up. I mean, it's like this vicious cycle that feeds each other. The more depressed you feel, the worse medically you feel, and the worse medically you feel, the more depressed you feel. So we try thinking about, how does your mood impact your ability to take your medication? And then we have this thing which I kind of added at the end called cultural tailoring, which is not really a section. It was really the entire time, allowing people to talk about all the things that perhaps they wouldn't talk about with their physician because the physician might think, it might take too long to explain why they do what they do. And what was nice about this is that we had a group of people, and they were not selected to be together, but they were just kind of the people that signed up at the same time. And often there was this kind of shared camaraderie among them. Oh, you do that, I do that too. Or, oh, I've never tried that, maybe that's a good idea. And it helped it move forward. So these folks in general were very adherent. So I didn't really talk about the different ways of measuring adherence, but this particular way, we used a pill count. So we actually called them and had them count their pills for us over the phone, which is challenging. I don't know if I would recommend that, but that's what we did. Certainly more accurate, though, than asking people if they take their medication. Because if you ask people if they take their medication, the answer is always yes. And do you take it 88% of the time or 92% of the time? Well, let's do the math. Over the last 2 weeks, I'm prescribed 12 pills a day, so how many pills would I have to have missed to do 88 versus 92? It's an impossible question that we ask people. Obviously, there's no accurate answer to that. So, each clinical trial or each study really has to think of a way of measuring adherence in a meaningful way. And the way that we chose with these over-the-phone pill counts, which ended up being a lot more work than we had bargained for. People, as it turns out, don't like to answer their phone when they have their pills in their hand and count out 120 pills for you when you call them randomly. So we spent a lot of time hounding people, but we got it done. So at baseline, our control group was 94% adherent, and our intervention group was 92% adherent. And that was just kind of a random difference, not different. And then at the end, which was 3 months later, the control group didn't get any intervention. They were still 94% adherent. Nothing much happened with them. That's not surprising. But this 92% adherent group went up to 98% adherent. And it was an increase, and it was a significant increase from baseline to outcome, and it was significant between the groups. The amount of change was significant, so it was very encouraging, right? So it was only 2 sessions. It was not very, the evaluation was extremely labor intensive, but the actual intervention was not very labor intensive. It was not expensive in any way. We just sat and spoke with them and encouraged them, really, with a kind of a guided plan for 2 sessions, and it had this amount of impact in just 3 months. So the second study is a study that we are doing here as part of the P20, which is the grant that the BHD has. And this was a study looking at, and this is a more ambitious project. We went out into the community and screened people about their risk for sleep apnea, and we wanted to see if we could get them to come to the physician to get a formal evaluation. So another way of thinking about it is we went out to the community, asked people if they had a problem that they'd never heard of, and then wanted them to follow up with a problem that they've never heard of, and now we've told them they have. So it was a challenge. So it was a community-based participatory research. I kind of took over this project when it was already in motion, but there had been years of effort that have already gone into that project, kind of developing the community-based partnerships, deciding that this was an important area of research, deciding how they were going to, the methodology, how they were going to do it, where they were going to reach out, what types of people, what were the kind of important factors. And then what was also challenging is that this was a true community screening, that we went really out into the community, so it was health fairs, food pantries, kind of everywhere that, Marilyn would take us. So I wanted to thank Marilyn, Dr. Fraser, who ran the outreach and the screening for our study. So, we screened 1,500 people in 3 years, and this is 0 of those people walked through our door. We went out and found 1,500 people. That's I think, really a tremendous accomplishment. And we found some interesting things. So 14% of the entire sample probably had obstructive sleep apnea. When I say probably, that's because we did a self-report questionnaire. The real way that you get diagnosed is by going to the physician, which is what we were trying to get them to do. And of those people, which is very high, the estimate in the community is about 3 to 4% is what the general population is supposed to have. So 14%, either our screen was a little not conservative, which is possible, or it could be that there are really high rates of obstructive sleep apnea in our local community here. 71% of those people have never discussed those symptoms with a doctor. So sleep apnea sounds like a sleep problem, but it's really a cardiovascular disease, right? It's a very serious medical problem. It just doesn't present very seriously. So people think it's kind of like insomnia. It's like, I'll deal with it or I won't deal with it, which is part of why we're getting out there, is to really educate people about its risk. And the typical treatment, if you have obstructive sleep apnea, is to get something they call CPAP, which is a mask that helps you breathe at night and prevents the closing of your airways. So 92% of those people were not using CPAP. So there were some people, a small percent of the people that were out there that we found that were already using this. Just as an aside, 38% of the sample had insomnia, and in 92% were not doing any formal treatment. That's, again, much higher than what national averages would be, and it's kind of interesting. I think that when you think about why people have insomnia, You might think of the Wall Street executive who is working so hard and they come back and they can't fall asleep. I think that there's other paradigms of why our patients in particular from this community might have difficulties falling asleep, or really maybe thinking about it, not the time or the space to go to sleep in the way that would be healthy for them to sleep. But again, 92% of them were not involved in any formal treatment. So we had, of those 1,500 people, we randomized 340 of them, 170 of them got this phone intervention. So what we did was we basically called them and we explained to them, we met them in the community, right? If you got the control intervention, we gave you a pamphlet. We said it's really important that you go get this checked out. We're going to follow up with you. Go get it checked out. Here's some information. And the phone intervention, we called people and we talked to them about what are their barriers? Why are you not able to go? Is it that you don't really think it's important? Is it that you don't, what are the issues? And, we keep a list of what all the issues are that people bring up. So it's really hard to get to a physician, right? And, this isn't, it's not the age of concierge medicine. You can't say, I want to go to the doctor at 7 p.m., right? You call the physician and you say, hey, I need a sleep assessment. And they say, okay, come, January 27th at 4 o'clock. You say, I'm working that day. Okay, come February 7th, right? So then you lost a month. It just doesn't, our healthcare system doesn't provide care in a way that is as flexible, perhaps, as many of our patients really needed. And we removed the financial burden. So if you had insurance, we billed it through your insurance. But if you didn't have insurance, we would pay for the physician's assessment, as well as the sleep test that we assume the physician might require. And what we found was that of the original group of people that we assigned to the intervention, 32% of them ended up going, with those phone calls, going to the physician, as opposed to in the other group, without any additional follow-up, only 4%. So that means 7 people out of the 180 or so ended up going to the doctor in the next 6 months to get their sleep checked out. So not getting a sleep study, we didn't even go that far, just going to the physician to talk about their sleep health. And then, we kind of had this, because it is a community-based participatory research program, about 40 of the phone numbers that we got in the community were not real phone numbers. So people, we paid them $10 for doing the screening, so people said, yeah, you can screen me, no problem, here's my phone number, and gave us a fake phone number. So if you exclude those people, right, because we never reached them, even if they didn't have the best of intentions. Perhaps had we reached them, we could have done something, but since we weren't able to reach them, if you exclude that, then about 48%, half the people that we ever spoke to on the phone, we were able to get to go to the doctor, which is not great, but it's certainly a lot better than 4%. So what I really wanted to emphasize is that, there are multiple challenges, for all of our patients and for ourselves in kind of getting people to become more adherent, to become empowered patients that really are knowledgeable about what it is. And if you think about, what we know about, so most of us have a pretty focused area of expertise that we've chosen and we've spent a long time developing and thinking about. And as a patient, you don't really choose your disease process based upon your area of interest, right? So you're being told, this is what you have to have, this is what you have to study up, this is what you have to do, and, that might be really challenging for people. So, to me, I think there's a lot of big questions that will require big answers, but some of the smaller answers might come from really just improved communication, giving time for people to express what their reservations are about what it is, and then being creative and brainstorming with them about moving forward and offering them support in doing so. And I'm happy to take questions now, or we could take questions at the end. Yeah, and partly because the disease often comes on slowly, so it's just kind of the way they've been for a long time, so they don't see it as like, oh, everyone's getting excited about it. There's a really great video, to your point, on I think it's the National Sleep Association has a video entitled "What It Takes to Get Your Man to Go to the Doctor," and it's a guy sleeping, and he is snoring so loudly that his little kids come padding into the room, and they're waking up their mom so that they can get him to be quiet. And the video is of the mom showing the guy the video and saying, look how bad your snoring is, you need to go to the doctor. And he says, it's not me, right? I mean, it's him with his wife and his kids. And then she looks at the camera and says, I still can't get him to go to the doctor, right? I mean, there's just so much intransience. People don't really want to go. They don't really think of it as a problem, especially sleep apnea. You don't really often remember it in the morning that it was difficult. So I think the number one reason why people go get treatment for sleep apnea is because their bedmate or housemate says, okay, you have to go. It's just, so bad. It is certainly a challenge. One of the things also is that the CPAP machines, or at least the traditional CPAP machines, are like a face mask, and people don't like sleeping with that. This is something that you hear a lot about. I'd rather die than sleep with that on my face, which is, I've only heard people that have not tried it actually say that. The weird part is that for most people with sleep apnea, they feel fantastic if they sleep with a CPAP machine, because they wake up and they haven't woke the next morning without having woken up 10 or 15 times or 100 times through the night, so they'll feel so much better. And there are also, I don't know if they're available through insurance, there are smaller sized masks that are now Bluetooth, so they don't really require as much of the wiring, and it's not as like medical feeling. They're trying to, it's got a fan in it, it's kind of got this like higher tech thing. So there are some people that are, they're working towards, some sort of technological solution for, they make the cords very short, the straps are very short so you don't accidentally strangle yourself at night. So sometimes people find it to be very uncomfortable and restricting. Usually most people who really have a problem feel much, much better that they're willing to tolerate, the kind of constriction. Yep.
Just about information, there is a group at NYU that does sleep studies, and they have a program where they'll give you an iPad with access to information, and you keep it for a month or longer, and it's been quite successful, and I know they're recruiting, so if you're interested.
They grew out of us.
No comment.
Okay. Anybody else? Comments?
Thank you very much, Dan. So the group that did not have the intervention really didn't go, most of them didn't go to the doctor. So what do we do with that group? How do we approach them?
How do we what?
How do we approach them? Because we know they potentially have a problem. What is the next step for those patients?
In terms of the study design, well, when we reached out to them and we found that they didn't go to the doctor, we began to do we offered them, would you like us to do the phone calls with you, not as part of the study, just as, but it's kind of strange, because if you're asking people, would you like additional help becoming motivated to go to the doctor, not surprisingly, almost all of them said no. And then, so when we first met them, we gave them a list of providers in the area with their phone numbers. We'd really tried to, connect them, let's say, as passively, but as warmly as we could. And at this point, there isn't much more that people were really interested in doing. For the intervention people, we were, encouraging them, and it ends up being, I think, because of our encouragement, a lot of them end up coming to our facility. That wasn't necessary. They could really go anywhere. It's just that it's hard. I think a lot of this is if you have a new problem, you want a friendly face. We're talking about community health workers or community navigators. That really, I think, in some ways, that was some of the role of what this motivational enhancement kind of took on, which was that, hey, I know this guy. He's okay. You'll wait a little bit, but he'll see you. It'll be fine. Okay. And then, when they came, it was like a more familiar experience to them as opposed to like dealing with a new hospital system and a new set of, expectations or experiences that they weren't really prepared for. Thank you.
I think that sleep should be a part of what doctors ask about, and they do not always do so. So how many people in here have had their doctors ask about sleep? Okay, so I think we have one answer to some of the things, the implications of these studies.
Unrelated to this, I just did a study with the medical school students where we asked them what's their knowledge about sleep disorders, what's their attitude about sleep disorders, and then what's their personal practice around sleep hygiene. So, our student physicians really know a lot about stuff, and they really are very poor at doing things. So, there's this kind of like, I don't know, complicitness, I think, that physician, or this, I don't know, weird feeling that a lot of physicians feel, because many physicians are working many hours, and they are not, they are cutting their sleep down to its bare essentials, and there's, really good data. So, there's protections now for residents, which is kind of interesting, because now the work demand has spread from residency both up and down. So medical school students now are absorbing more of those. There's no protections for medical school students, so they're working longer. But what's even more interesting, I think, is that junior faculty are now picking up the extra shifts instead of it being the residents who are doing it. And, they have no protection, federal or otherwise. So they, you have to figure out what the ramifications are going to be for these folks when there's this demand that they do this. And, we have pretty good data which says that, under 7 hours of sleep, you start to make poorer decisions. So if you're chronically getting, 5 hours of sleep, is that the person you want making life and death decisions for you? It's, it's a challenge. Right. I mean, that's where we see it, is when they drive home after the shift. That's where the data is, right? Where there's so many, X many accidents for physicians returning from the overnight shift. But you don't really get to see about, well, what was he doing right before he left? Oh, he was doing open heart surgery. Okay. So, you don't get to, they don't fall asleep while they're doing surgery. We know that. But, is it possible that they are somewhat compromised? I would say probably.
Okay, thank you.
Thank you so much, Dr. Suka, for engaging us in such a critical conversation. Now I have the pleasure of introducing one of the busiest women here at SUNY Downstate, Dr. Marilyn Fraser, who is not only the Chief Executive Officer of the Arthur Ashe Institute for Urban Health, she's also the Assistant Professor in the Department of Medicine here at Downstate and the Co-Director of the Brooklyn Health Disparities Center. And she will be engaging us in a talk on patient community engagement, keys to better adherence. Dr. Fraser.
Wow, thank you. So 5 hours of sleep is not good. So today what I wanted to talk to you a little bit about is adherence, but talking to you about it in terms of community engagement and some of the approaches that we have used. So I'll talk to you a little bit about the Arthur Ashe Institute for Urban Health, and I'll talk about some of the factors that impact adherence. And then we'll talk a little bit about partnerships as we look at solutions with partnerships, community engagement, CBPR, which you've heard a lot about, and then we'll just summarize some of the work. So the Institute, for those that don't know about the Institute, I hope everybody knows about the Institute. It's a nonprofit organization that was founded by Arthur Ashe just months before he passed away. And a lot of our work that we do centers around community health empowerment. We were located right here at SUNY Downstate Medical Center, and Arthur Ashe created it in response to concerns about healthcare delivery in America. So a lot of our work centers around health education, health promotion, meeting people where they are. So we would go into beauty salons, barbershops, and talk to people in various walks of life. And another aspect of our work is our Health Science Academy, because we believe that we need to start earlier in terms of educating people about health and educating them about health promotion, educating them about cultural competence, because they'll be the next generation of our health professionals. So patient adherence was already defined. I know Dr. Booth and Foster did a wonderful job in talking about adherence and talking about compliance to some degree. And we have moved from compliance because compliance puts more of the burden on the patient and more of the cost for the issues upon the patient. So adherence brings us a little closer. I think we still need to do more work where that term is concerned. But we'll be looking at adherence in terms of the degree to which person's behaviors corresponds to the agreed recommendations. These are some factors, and this was taken from the Global Research Report that was done in 2011. And I don't know if you're able to see it, but major factors are patient-related factors that impact adherence. We also have healthcare systems and provider factors, therapy-related factors, cost. We know that that's a big factor, the condition and the disease, and socioeconomic. And when we're talking about patient-related factors, we're talking about inadequate knowledge, perceptions of risk. We talked about that earlier this morning because sometimes people may perceive a disease as not being that detrimental to their health, and therefore they will not adhere to medication or regimens. And even misunderstanding of treatment. So when Dr. Allen spoke about, Dr. Alan Lewis talked about just the communication. There has to be two ways, right? And misunderstanding of the treatment instructions and even thinking about the follow-up and just forgetting to take your medication because of the chaos that may happen in your life. And when we look at healthcare systems, we're talking about reimbursements and inadequate reimbursements. We're talking about health insurance, poor medication distribution systems, and barrier to care by providers. Training, poor patient and provider relationship, and the time that's spent in communication and the style in which communication happens. Therapy related talks about drug effectiveness, how medication is taken. Is it oral? Do I have to take an injection? How often I have to take that, how many times my treatment might have changed over the course of my illness, and keeping up with those things, the complexity that comes with duration of treatment, having a long treatment regimen. Cost-related, co-payment, out-of-pocket costs that people may have to shelf out to have medication. The condition and the disease, we're talking about severity of symptoms. So sometimes if something doesn't seem as severe to us, we may not pay attention to it. And sometimes we may not think of we may perceive the risk as not being that great, not thinking that if we don't recognize the problem right now, later on we may have more complications and it may be more detrimental. And then socioeconomic issues. We've talked about social determinants of health quite a bit this morning, and thinking about some of the demographics, income issues, employment issues, social support, and of course, culture matters, and culture and beliefs matter quite a bit. So what do we know? We know that information is largely in the domain of health professionals and institutions, and sometimes it's often hard to navigate those systems because things are not shared on both sides. So where the patient is concerned and where providers are concerned, things may not be shared. And the cultural communities need to weigh in terms of talking about the things that matter to them, and also educating institutions and educating providers about culture is important as we move forward. Decision making, thinking about who makes the decision, who are the people that we need to focus on, who are the decision makers in the family. A lot of times the woman in the family may be the one, the primary caregiver and the one that's making the decision. Community elders, folks that may be in churches or faith-based organizations, and they may be the primary decision makers. When culture comes into place too, in terms of some cultures leaving the decision on to the provider and thinking that, the provider is trained to know these things, and so whatever they say, I don't need to question that, I need to just follow. And so all these things are important when we're talking about communities and when we're talking about institutions as well. And then religion, and so we know that faith plays a big part in it, and then we have to think about when does faith conflict with medicine, or how should when should providers think about how do they intervene? And then is there a role for the religious leaders in terms of caregiving? Things that we have to consider: cultural competency, and this speaks more to educating providers regarding in relation to changing demographics, culture that matters. Health literacy, we speak more about the patient education here, and the social determinants of health that you keep on hearing and you've heard a lot, because it does play a role, and those include the housing, the food security, the education, employment, income, race, and all those things. And then the importance of our partnerships, having effective partnerships. We know the definition, I'm sure, of culture, and this is shared systems of values and beliefs, and it's shared patterns of behaviors, and those things, it really matters, and culture does count. So in order for us to have optimal patient-centered quality of care, we need to pay attention to the culture, and culture on both sides, right? Because just because someone may be of the same culture, they may not understand everything the same way. And with providers and patients, we need to pay attention to how culture matters in that. We know culture influences a whole host of things. So culture influences our attitude, the expectations that we may have, our perceptions of various things, our priorities, our coping style, how we decide to cope with something, our values, and our health beliefs. I know, as Dr. Buden Foster talked about the various things within certain cultures, the herbs and the different bushes that you'll use. And I remember my grandmother could give you a bush for everything. So for a cold, there was a different one. If there's fire, there's a bush that you'll use, or a tea that you will use for something else. And those things still prevail today, and sometimes we don't ask people what are the different things that they are using. But they believe in it. I've gone out into communities a lot of times, and people may have high blood pressures when we take it, and they say, oh, I know what to do. I'm going to go home and take some lemon and some salt, and it's going to be done. It's going to be down tomorrow, yes. And they take Epsom salt, and they take salt, and it will be down. And so there are a host of different things that we are just unpacking when we talk about culture. And it does influence the decisions about where you'll go for treatment, how you'll go and seek treatment. People from different countries come with different health systems and may have different orientations about the process of seeking and obtaining care. And you come from systems where care may be free compared to going through insurances and going through paying for a provider. So it's a different system, and people need to understand that on both sides, as providers and also as patients. And when we go to think about our solutions, we know that it needs a multi-pronged approach. We cannot focus just on the patient. We cannot just focus on the provider, the systems. We need to develop partnerships and effective partnerships. We need to foster relationships, and we need to inform policy so that changes can be made. And the reason I put our slide up over the Brooklyn Health Disparities Center, because I think that's a unique partnership, and that's where a lot of things start. We have a partnership that you have a community-based organization, you have an academic institution, you also have a government entity, which that's strange in a sense because a lot of places do not have that. We usually talk about community academic partnerships a lot, but there are not a lot of community academic and government partnerships. And our CBOs, we have a group of 12 community-based organizations that advise a lot of the work and inform a lot of the work of the center. So that's important, and that's an important starting point as we address health disparities, but also as we address those different issues around adherence and so forth. You've heard about community-based participatory research today, and basically this is a great model of telling you about what that is in terms of the community being at the center of that model, in terms of the development of the research question from the beginning, going all the way to the implementation of that, interpreting the research findings and disseminating the results. So when we were applying for our grant, our center grant, we had our community-based organizations through a Delphi process identify key priority areas that we should be focused on. And through that process, we were able to develop a shared research and policy agenda, which guided our work. And so high on their priority list, high on the community's priority list, were HIV and AIDS and cardiovascular disease. So our projects that we came out with were Barbershop Talk with Brothers, which is an HIV-focused project, and our sleep apnea project, which, as Dr. Suka mentioned, that speaks to cardiovascular disease. And the benefits of CBPR is strengthens intervention design and implementation. It also, the knowledge gain benefits the community. It provides resources to the community. It also increases trust because the community is an active part of the process of developing something that's culturally tailored to them. And it enhances sustainability of programs because you have folks that are trained that will remain in those communities long after we have left those communities. And in fostering relationships, a lot of our work deals with community engagement and going out, as I mentioned, and meeting people where they are. So we have conducted work in barbershops, our barbershop-based programs, and we have developed curriculum for barbers to speak to their customers about various things. And the barbers are close to the customers' ears, and one of the things that when they're that close, they could talk a lot, and you're in their hands, so to speak. And one of the things that barbers like us to talk about is the history of the barbershop, that years ago, the barbershop was a center for health in a sense. Surgery was done there. They had bloodletting that was done in the barbershops. It was a dentistry place that they went to. And barbers like to think that, okay, you know, we're giving back to the community. And so our history speaks to health and being a health center. And we can give back to that process, or we can engage our customers, again, to promote health. So we have done a lot of work in barbershops across Brooklyn, and we've also done work in salons, because our stylists tell us that they're the ones that women talk about everything to. And I know it happens on the other side with barbers too, and the men that visit barbershops, but they feel as though they're the counselors, and they're the ones that people may talk to, and they want to intervene with a message that will help them to promote wellness, and also to weave beauty and health together so that they can improve health outcomes. And when we think about policy, I know we're in a time where we're looking at healthcare transformation and the delivery system reform incentive payment program, or DSRIP. And that's focused on cultural competency and health literacy. I'm not sure how well it will work, but the plan is promising. It establishes a community-based approach for reducing health literacy and linguistic barriers, and community engagement and training. And those things are important because we need to train the next generation of healthcare professionals, making sure that they're culturally competent. We need to also meet people where they are, raise awareness. One of the things that we have used in addition to just educating folks about an illness and treatment, we also empower people to talk to their doctors, and in giving them questions that they can ask their doctors. And sometimes people are often apprehensive about asking a physician questions, depending on which culture you're from, but that helps them to open the door and to start some of those conversations. And I like this chart. It's a comprehensive patient adherence framework, and it was taken from the New Frontier in Patient Care. And it talks about how we can address patient adherence and different points in which we need to address that. And in the upper right-hand corner, it talks more about understanding patient leakages and their root causes. What are the causes of adherence? And then collaborating across stakeholder groups. We have different stakeholders that we've mentioned today, and we need to collaborate, and we need to have those essential partnerships. We need to also maximize places where we can reach our patients and reach people to talk about health education and promotion and adherence. And then ensure that we are investing in the group that needs to be addressed. And then enrich the patient experience. What does coming to the doctor mean for that patient? What does having good health care mean? Making sure that we're thinking about what the patient needs to sustain their experience at a doctor. And then creating a mechanism where we can have feedback, and positive feedback, negative feedback, but there is a place that we can have those communications that will help, and that will elevate patient adherence. And then we need to just consider adherence, as stated before, early on when we are designing drugs, when we're starting out talking about an illness, when people are learning about an illness, we need to include adherence as part of that. So this is what I really wanted to just talk to you about today, and just leave you with that. This is a quote that I've become more and more to like as time went on, that I know I could never forgive myself if I elected to live without humane purpose, without trying to help the poor and unfortunate, without recognizing that perhaps the purest joy in life comes with trying to help others. So thank you.
Do we have any questions, comments? Okay, you guys are getting close to that lunch need.
Yeah, I know I'm
I
between
understand.
lunch and...
We have one last segment we'd like to do before lunch, with your permission. I'm going to invite Betty Jung, who is also on our executive committee, to come up, and she will bring with her some special people onto the stage who will share with us really exactly what it's like to be a patient, and their story about how it's been for them.
I just want to say these are members of our Brooklyn Diabetes Club that Linda Go and I have coordinated and hold on a monthly basis for the past 15 years. And I just want to say this is one of the strategies in helping the patient becoming much more adherent to the medical regimen and also empowering them with knowledge. We also run the Brooklyn Kidney Club, which one of them actually also is a participant. And we also have monthly community health seminars on many different community health topics that is of concern to the community today affecting the medical condition. So what I'm going to do is I wanted the audience to really have the experience of what it is like from the patient's perspective, a visualized experience of what it's like when they were first told that they actually have a medical condition by their physician and that they have to manage it. So up on stage to your left is Hyacinth Brathwaite. Raise your hand. Cynthia Clarke, Ella Toney, and John Hackenberg. So I would like to ask this question, and they're going to share their personal experience. When you were first told that you have a medical condition, tell us your experience. How did you feel? Anyone can start.
Good afternoon. My name is Cynthia Clarke. I'll just share briefly. For me, when I was diagnosed as being diabetic, actually, all along the way, my doctor kept saying to me that I was borderline. And I really didn't pay any attention, that much attention to the fact that he was telling me I was borderline. I was like, okay, no problem. But this one particular day, the secretary called and she asked me, she said the doctor wanted to see me, and it was a Saturday. And I said, okay. And I woke up that morning and I really didn't feel that great, and I said, I'm not going. You know, I'm not going to go to the doctor, I'll cancel it. But my mind said go. And when I went to see the doctor, when I went to the office, I noticed there wasn't anybody else in the office. I was the only one. And the doctor called me into the office and he told me to sit down, and he said, I have something to tell you. And he said, I want you just to relax and, you know, I'm going to tell you what I need to tell you. When he told me I was diabetic, put it mildly, I freaked out. I really became very agitated. I started crying. I thought it was the end of the world. It was just very devastating. It was a very devastating thing to me. But the thing that was good for me was the fact that my doctor was very understanding. And I think that's one of the important things with people who are diagnosed with diabetes or that are diagnosed with any illness, that your doctor needs to be there and needs to understand. My doctor sat with me for at least a half an hour to almost an hour, and he just held my hand and he let me cry. He let me cry, and after I cried, he said to me, it's not the end of the world, we're going to get through this, and this is what we're going to do. And we went through a whole regimen, and I have to say, I'm a nurse, okay? And I've been a nurse for 37 years here at Downstate. And it doesn't make a difference whether you're a nurse, whether you work on any type of job or whatever. But when anyone tells you anything about an illness, you're just an ordinary person. All of that medical profession that you know, all that knowledge goes out the window. So it's very important when you do see your doctor that you have a communication with your doctor, and that whatever goals you make with your doctor, that they're goals that are understandable for both of you. Not just goals that the doctor makes for you, but that the doctor understands that these goals are workable goals for you.
Mrs. Tony?
My name is Ila Tony. How I found out I had diabetes was, I worked in a hospital, and the in-service instructors came, it was in 1996, they were demonstrating a new testing machine to do the blood. So I said, okay, after they finished, their demonstration, I said, well, check my blood sugar. So then I just checked my blood, so I give them my finger, they stuck it, and there they saw, it was higher. So I saw an endocrinologist that same evening, and it was about 200 and something. So that's how I found out I was a diabetic. So I said many times, if you have the opportunity also to do testing anywhere, because I remember years ago, people might go to an affair, and then they may have testing people out there, and they test their sugar for the first time, and they found out that they have diabetes. So then after I found, but I did not, acknowledge. That was in 1994. I did not acknowledge I was a diabetic. I had diabetes, and I didn't really comply with anything at all until 2 years after, in 1996.
And what motivated you to actually act on it? What motivated you to actually act on taking care of the diabetes condition? What happened?
Well, after they found out, then the doctor counseled me. He put me on tablets. I think I started off on glucophage. And I noticed I used to have edema with it. So I told him, I'm not going to take this medication because I'm having edema. And that's, swelling off the feet. Anyhow, he switched me to another type, which was glyceride. And I was like, so you go down. And I noticed glucophage now is the same metformin. They just changed the name now to metformin as opposed to glucophage. But I'm taking metformin now, and I'm doing much better.
John Hackenberg, would you like to share your experience from the day you were first told?
Doctor found a high level of sugar in my urine, so he did blood tests. When he called me back and told me I had diabetes, I was in complete shock. Couldn't believe it. Because a lot of things started going through my mind. My mother died from complications from diabetes when she was just 59. So that's the first thing I thought about. Life had just been cut short because I had seen all the things that she had gone through, the operations, the complications, the heart disease. And I was looking ahead and seeing a lot of that for myself. So he put me on medication immediately. Metformin, Actos, and later on Januvia, and now Invokana. And the hardest part is that as time went on and the number of pills increased, I was put on medication for Zocor for cholesterol. I was put on Tricor because my triglycerides were a little high. And slowly, over the years, the number of pills increased. And although I take them on a regular basis because I have a lot of interest in staying healthy, it is a bit of a chore. The side effects from some of the medicines, particularly metformin, are horrible. I found out very quickly on that if you don't eat, when you take metformin, you have awful stomach aches. But some of the other medicines, I didn't feel like there were any effects at all. I mean, I couldn't see exactly what they were doing, except that my A1C was under control. So I assumed that that they were working without without a lot of fanfare. And today it's still under control, and I'm happy about that because now that I'm in my 16th year or so of diabetes, I realized that this this was about the same time in the course of my mother's disease, when she started having the most serious complications. And she ended up in heart surgery a year later, which resulted in her death. But so far, I've been fortunate enough to be spared all of that, and I continue to stay active, to try to eat right, try to eat less, try to do everything that I read about and see as helpful to treatment of the disease. Better, more comprehensive care, develop treatment. Maybe at some point, but I don't know when that will happen. But I keep watching research news. I keep looking on the internet, watching health shows on TV to see if there's anything new.
There's a lot of options available to learn about your medical condition. Mrs. Brathwaite, would you like to share your story from the day you were first given the news that you have a medical condition?
Yes. Well, my story was my grandmother was as a diabetic when she was 46 years old. She was a midwife, and I used to help her as a kid to test her urine. In my country, that was how you tested your urine. And she was always like 3+ or 4+, but she never went to the doctor. So she was taking herbs, sorcy, that was her medication. And her food was like steamed fish or meat. But I never thought that I would be a diabetic, because how I started out, they found that I was anemic. And I was going through testing, and then they found out that I was like borderline. And they started to give me tablets that didn't work, but I was in a research at Rockefeller Center who introduced insulin. But after 2 months, I was thrown out because I was putting on too much weight, because I was eating. When I get out from the research, they couldn't follow me up because I was putting on a lot of weight, because I was hungry, I was eating. I didn't understand what it was, and still battling with the anemia and the insulin. So I was at St. Luke's Hospital where they was checking me out, and they couldn't find out. And they said I was a syndrome X. My body was refusing to use the medicine that I was taking. So we had a battle fighting, changing the medications. I was on half tablets and half injection. Then from fighting and the education is very, very important. And you have to have a team of doctors. You got to go to your kidney doctor, to your heart doctor, everybody. And right now, I'm on 5 injections, but small doses. And it's much control, but it's very, very hard work. Nutrition is very important, and the education. Very, very important. You have to be your own advocate of looking after yourself. And that is my story. It's very, very hard work. I don't want to get the young doctors afraid, because it's a lot of work, And I recommend, I applaud the doctors that is doing this work. It's very hard, because every case is different.
Were there any time in your life that you went off on your regimen? And what did you do to get back on track?
Sometimes, but I get back very quick. Very good. You'll be tempted, but it don't last too much. You have to know how to cheat. Because you'll be cheated. If you eat a whole apple, you'll be cheated. It's only a half an apple, okay? So, you say, oh, well, I wouldn't do that.
We realize that
You realize
diabetes
that.
is not
Yes.
a
And
disease
if
where they
you
actually have
really
any
want
vacation.
to eat a piece of chocolate, it's not very good. Because even if you have low blood sugar, that takes a long time for that sugar to come up. So please, just take a little piece, and that would be.
How long did it take anybody for you to change your lifestyle? How did a change in your lifestyle is associated with your medical condition? How did it affect your life, personally and your family? Anyway.
Me with the cooking, my husband didn't have diabetes, but I put him on that. I put him on my diet.
Mrs. Tony, how much did this having diabetes change your life?
Yes, it changed my life tremendously. Because when I went to the doctor, of course, you do your blood test. So you look at the results. I always take back home my results anytime. Here, my fasting blood sugar is good because you fasted all night. And then the A1C comes back like 8.6. I remember once it was even 8.6. And that same day I came to diabetic lecture here. And I remember saying that to Betty. She even called me about 10:30 the night and said, here are some endocrinologists' phone numbers. Please go and see someone, and give me phone. But I didn't. I did not follow through because I always just did not pay any attention at all to my diabetes. As I said, I didn't accept the fact that I had diabetes for 2 years. And then a year after, I noticed all along the A1C stayed high. And another thing that I didn't do was take my cholesterol medication. I would wake up on mornings, check my pulse, and the pulse rate is under 60, and I just wouldn't take it. Not adherent to my things. So therefore, one day I woke up with a chest pain. I went and saw my PCP. He sent me to the hospital. I said, no, I went to a wake yesterday. So I think the food I ate, I went home and drank ginger and all that. The next day it got worse. And of course, I had to go straight to the emergency room. They ran tests. Then they said, well, something, you have an MI. So therefore, we'll be running a cardiac catheterization tomorrow on you. And based on that, maybe a stent will have to be inserted. And that surely did occur. Since then, now I'm really not trying my best. I'm trying to follow the regime as I'm told. And recently, I've started going also to some diabetic lectures that talk about the carbohydrate, regime, because I continue to eat everything. If I go to the bakery and they have fudge, I'll buy it. If they have peanut sugar cakes, I'll eat it. My sister might send a fruit cake for my sister or brother, and I tasted it and it tasted fine. I wouldn't even share it. But since I'm doing this carbohydrate, I now start really truly understand diabetes. Now I became I found it out at age 55. I'm now 77. So I do my exercise, I go swimming, and I'm really now sticking to this carbohydrate diet. And I think it helps.
Thank you. I just wanted to add, of all the types of community seminars and clubs that I do coordinate, this is a representative of gender percentage that I am seeing in all of my group meetings. If you ever come to any of my group meetings, no matter what, topic I hold, the majority of the audience is, guess what?
Women.
Women. So we need to get a male perspective. John, why is there such a small percentage that actually come to educational seminars?
I think the reason is basically the male attitude. Men have seemed to me to have a harder time accepting the fact that they are ill. They have the feeling that somehow because they're men they can tough their way through it, opposed to just giving into the treatment regimen. And they just hope that maybe they can make the adjustment on their own by exercise. They have the male ego gets in the way. I mean, they feel like, well, you know what? I can handle this. I'm a guy. I can handle this. So they're a little slower to come around and accept the fact that they have an illness that requires education, because they feel like they can do it on their own.
So it's something to look at. We do have to really pay attention to the men, but unfortunately they are the ones that get diagnosed, many of them at a very late stage. So it is the men that we really, really do need to reach, and I'm so happy that Dr. White has a brothers program, barbershop, that really are reaching the men in the community. We can entertain questions, some questions, so we can go to lunch. So anyone has questions?
Give a hand to